Working with the fibula of the lower extremity, our goal is to increase inferior distraction in order to disengage this proximal tibiofibular joint. The reason for that is because this joint can become compressed together with the assistance of the biceps femoris attachment after there's been some type of injury into our patient's lower extremity. As I said in the previous video, with patients that have suffered from an inversion type of sprain, the calcaneofibular ligament and the peroneals will be pulling this fibula in an inferior fashion, which then causes a lengthening to occur through this biceps femoris, which when goes into a protective mechanism can jam this fibula back up into the tibia shelf where it's attaching onto. If we have any patients that are suffering from an eversion sprain, well then calcaneus can actually jam into the distal fibula, jamming that fibula back up into the proximal tib-fib joint. So we really do want to increase some functionality through this joint. Now the position that we place our patient's knee into is one where we have our elbows resting on the table, taking the full weight of our patient's leg. Now what I don't want you to do is I don't want you having your elbows off the table. The elbows can rest on the table, and this is a very effortless, easy technique to perform as the therapist. Now what I want you to be able to do is have your patient's calcaneus resting in your hand. I want you to be able to palpate that calcaneofibular ligament, and I also want you to find again that middle joint space at the knee between the lateral condyle of the femur and the lateral plateau of the tibia, and then find that proximal bony protuberance of that fibula where the where the biceps femoris hamstring attaches onto. In order to assess the movement at this proximal tib-fib joint and the fibula in general, you want to, in a direct technique, you want to take your patient's foot into an inversion position, which will or should pull this fibula in an inferior fashion. We want to be concentrating on our thumb at the proximal position while we take the foot into that inversion position, because we want to be assessing what the motion, the permitted motion is at that joint. If there isn't any motion at that joint, then it needs to be treated and we need to draw this fibula inferiorly. So let's see what that looks like with our patient. In treating your patient's fibula and assessing for its permitted motion, what we do is, again, we have our patient's calcaneus in one hand. We've found the proximal head of the fibula with our other hand, and we're slowly going to elevate the leg, keeping our elbows on the table, being able to find that distal tendon of the biceps femoris where it attaches onto that proximal fibular head, and we have the calcaneus in our palm down at the distal end. So what I like to do is remember that we don't want our thumb hyperextended at that proximal end. We want to make good contact with the proximal surface of that fibular head. With our hand at the ankle, we have the ability to take the foot in from an eversion into an inversion position. And while we do that, we can assess to see if there's any movement that's happening at this proximal head. Now you can see that we have some movement through the skin, but we don't have any movement at that joint. So I should be able to feel some movement happening at that joint, and I can't with her. So this technique is appropriate for her joint. So what I'd like to do is engage the tissue, bone-on-bone contact. I like to take her foot into an inversion position, and then locking my thumb onto the proximal portion of that fibula, I like to draw it inferiorly and try and gap those two bones apart from one another. It's a very minimal amount of space that you're going to be gaining. Now, if you wanted to incorporate some activity from the patient with this, I would actually ask my patient to invert the foot a little bit more, which then has the ability to draw that fibula further away from that proximal attachment at the tibia. If you find that your thumb is slipping off of the skin, you can slowly reposition and continue the treatment technique and wait for an increase in elasticity and suppleness to occur through that joint. We'll get her to relax while I'm holding the joint in that position. We can go back to our start position, find that proximal fibular head, take the foot into inversion, and then go back and forth. And there is now an increase in range of that fibula moving through an inferior distraction. It's not just the skin, it's actually the head that is moving inferiorly away from its attachment at the tibia. So engaging that tissue and reestablishing proper mechanics and fluid dynamics and stimulating the mechanoreceptors through this tissue, we are assisting the body in recreating better proprioception, balance, and coordination through this area, creating more functionality through the environment, through this bone, and through the lower extremity, and allowing the ankle to actually have a little bit more range also. So this is a great technique for any of your patients that have either had an eversion sprain or an inversion sprain that have caused a decreased range of motion to occur at this proximal tibiofibular joint, and it's great to get that inferior distraction happening through this bone. So try that with your patients, and I'll see you in the next video.